So Dr. John Roberson, oral and maxillofacial surgeon with a passion for pharmacology, is going to help us understand things a little better. You have the floor, John.
All right.
And thanks for coming and sharing with us.
Thank you, Sammy, for having me. All right. Okay, good morning. I have a lot to cover. I do a combination of advanced medical emergency preparedness with pharmacology as well. And then we also have just our separate speak on just medical emergencies and pharmacology. So today I'm gonna throw about 3 hours into about an hour and a half, 2 hours. So we're gonna motor a lot and get through this. I am a private practice oral and maxillofacial surgeon. I'll be back in the office on Monday like every one of you. I've got a double jaw all on 4 with zygomatic implants and pterygoids Monday. So that's what my day is looking like on Monday when I get back. Okay, so let's get this going. There's my disclosure. There's a disclaimer. Anything I tell you here, I can't prevent a bad outcome in your office, okay? On medical emergencies, the topics we're going to cover today, medical emergency preparedness, emergency drugs, some pharmacology. We're going to go into patient red flags. We're going to go into case presentations, and we're going to talk about legal ramifications and aspects. This is very important about this topic right here. There's only about 2 or 3 of us out there speaking on this subject matter at all. And when something bad occurs in your office, it could change everything. And we're going to see examples of that. I mean, I just got an example last week. I lecture about every 2 to 3 weeks now, and there seems to be a patient death every time. And all of this should be preventable. We shouldn't have people dying in our offices. So I'm going to reinforce all of this today. It's risk-proof your practice or risk losing your practice. Every one of these dentists I'll be talking about shortly had no idea that this would happen in their office, all right? Then it went down, and chaos ensued, and then a bad outcome. So my goal today, number 1, reduce patient deaths in dental offices. Number 2, reduce dentists losing their offices due to a negative outcome. And number 3, if I can just prevent one from happening in today's lecture, I've done my job. So to me, I think this is the most important presentation you can do. I won't make you any money. I'm not going to show you how to place the latest implant. I'm not going to be like Rich and show you how to use PRF. And by the way, I love PRF. I'll be using it Monday as well too. What a great product he's got. So your preparation is the most critical thing you can do. Not just you and your team. A medical emergency is not going to be handled by one person. Now, unfortunately, we're working against the learning pyramid. If you look at where I am right here, audiovisual, about 20% of this is going to be retained. And unfortunately, when you go back to Ebbinghaus, he came up with the forgetting curve. So today, in 1 hour, you're going to forget 56% of what I said. And then 66% after the end of the day. This is why you got to have reinforcing cognitive aids. And we'll go over all of that. So please remember, the risk for medical emergency is never 0. They can happen any given time. None of us have that crystal ball. So what happens if we come face to face with a medical emergency in our dental office? A, panic, forget life-saving skills. B, death of a patient. C, loss of dental license. D, sue beyond malpractice limits. And E, closure of your practice. The answer is all of the above. I got multiple cases of dentists that were sued beyond their policy limits. They went bankrupt. I just got back from another state, heard a case where not 1, but 2 dentists lost patients. It's traumatic to everybody. The hygienist interrupted me in my lecture and told everybody. You could tell she was suffering from PTSD, no doubt. And she said, not only could you lose your life, you'll lose your wife. The extended families wound up all hating each other. One dentist went into research. The other dentist shot and killed himself. We sit there and question everybody, oh, I would never do that. We don't know. We're not in that situation. And can any of us say, I'll never have a medical emergency? Absolutely not. Can I prevent a medical emergency? No. We can come close. But no matter what we do, it can still go down in the office. So what if I were to tell you 10% of you sitting here today would lose your practice due to a medical emergency? What would you do? What if I told you one of you in this audience would have a patient die in your practice lifetime? What actions would you take to prevent this catastrophic event? I don't know if you know Larry Sanger. He's one of the other gentlemen I was talking about besides Stan Malamed. I don't know of anybody else really talking on this subject matter. It's getting to be less and less. Swiss Dental had me speak on a virtual webinar. We had a great turnout and great feedback from everybody on that. But Larry has done a lot of research and has really pestered a lot of state dental boards on this as well, too, trying to get information about it. And I'll get into that in just a second. But he has found that whenever a negative outcome has occurred in the office from a significant event, that office is closed in 30 days. So let's prevent that from everything we learn about today. So invest in a medical emergency program, preparedness program, just like you would your monthly retirement plan. Why? Because they both determine our futures. We all work hard every single day, Monday through Friday or Monday through Thursday, whatever you work. Our goal one day is to retire and enjoy, all right? Let's not let a medical emergency ruin that, because it has financially ruined dentists. So we know there's a storm coming. What are we going to do about it? Are we going to get prepared? I come from Hattiesburg, Mississippi. When Hurricane Katrina came through, we weren't prepared. We became a third world country for about 2 weeks. But we are now. So never get too busy making a living to forget how to save a life. We got to look at it like our storm is coming. And remember, you are the help until help arrives. Don't bet your future on what hasn't happened in the past, because I've had many people tell me before, oh, I've never had an event. Well, how do you know what's going to happen tomorrow? That's just like I heard an oral surgeon say he's never had a dry socket. So these are some of the common procedures that lead to liabilities right here, okay? And we'll get into those in just a minute. So, from a medical emergency preparedness, you have a legal imperative, a moral imperative, and an ethical imperative. We want to be like that dentist. But then we have the medical emergency unpreparedness offices that I call them. All three plus a financial downfall. We don't want to be that person scratching their head when a medical emergency is going down. So your state of readiness, you know it right now. You know, am I an MEP or am I an MEU? And as we go through this lecture, we can change that entire mindset. There's no in-between on an MEU office. So the ABCs right now, always be concerned that a medical emergency could happen. Always be committed to medical emergency preparedness. Always be correct when that medical emergency goes down. And I'm going to show you a list of what we call the DOMES 24, about 24 medical emergencies you should know frontwards and backwards. You got to practice and practice and practice till you don't fail at them. Always be checking that all of your equipment is in date. When we get to our section on the emergency drug kit, I'll talk about that. Always be certified to whatever you may have in your office, whether it be BLS, ACLS, and then some new products coming out, ALSDA, ALSDH, and ALSD, and Mr. Goldman can talk about that later. Always be careful on the certain patient population we're treating. Make sure we go through that medical history carefully. Always be capable of handling that medical emergency. Always be competent during that medical emergency. And always better call 911. That's the number one legal downfall of every dentist in every situation I'm going to present here today, is the fact of calling 911. I'm going to throw all these acronyms at you, all these little mnemonic devices, just to implant in the head, hey, if something goes down, if that patient just passes out in my office, 911 is called. No ambulance is ever going, or the paramedics or EMTs will ever ostracize you for calling them, all right? Better safe than sorry. And we'll get into that when we get to the ambulance here and just say, and then always be compliant with your state board. And of course, always go back to the ABCs. Airway, airway, airway. The ventilatory compromise seems to always be the issue coming up. So the ABCs of emergency drugs, everybody practice sedation in here, or are you just local anesthetics? Or is it a little bit of both? Okay, great, awesome. Make sure you have the proper monitors and all that. I just got a case last week. They're saying no monitors were on the patient. And a lot of propofol was given to that patient. And that patient died. And the coroner is already lambasting the dentist about that as well, too. And the coroner happens to be a CRNA. Trust me, anesthesiologists, CRNAs really don't want any of us in this room to be sedating. I love it. I think it's great for our patients, and I think as a dental profession, the last thing we ever want is a medical board to step in and tell us how to run our profession. But it's hard when you have cases like that just occurred last week. I also speak for CREST. Okay, so the 6 links of survival. All right, these 6 items, first of all, if you have those in your office, you're building your defense right here. And that's one thing I'm going to talk about is building that strong defense. You might have a negative outcome, but your defense team can go fight for you. And that's critical in maintaining everything you've got here. Trust me, I've got over 20 years of experience in this area, looking at cases after cases, and I've just compiled everything, and I've been blessed to have a partner in the office. Now I can start traveling and preaching this message again. So let's talk about the 5 deadly misconceptions. Okay, long ago, another oral surgeon and I created something called the emergency response system. And we went to trade shows because many vendors like to carry it. And by the way, we never told them we were oral surgeons. We didn't even have doctor on our tag at all. We did that on purpose. So these were comments coming from our colleagues when we said, hey, would you like to get prepared for medical emergencies? So, I mean, okay, there's the ones that we always hear all the time, okay? Hey, number one, we will not panic during a medical emergency, or BLS is all we need to know. All right, so then they kept growing. The physician's clinic is across the street. That's my plan. That didn't work too well for a dentist. One time they had a medical emergency, and the dentist panicked, and so the assistant grabbed and carried the child across the street to the physician's office, and the child was already dead. We'll get into negligence and gross negligence in just a minute, and y'all figure out which one is that coming up. So at each show we went to, we'd hear more and more and more. Look at number 11. My brother is an attorney. Okay, what is that going to do? That's why I have malpractice insurance. Or this one right here. If it was important, the board would mandate it. Go after them, not me. So that's an interesting concept. Because if I knew if I did everything right, and I was had more than my state board, and they were trying to close my office, I'd convince my defense team to go after the state board. Oh, here we go. I teach at the dental school. Okay. And who needs a drug kit? Nothing's going to happen. Wow. So it kept growing. All right, how about puff, blow, and go? Where are you going? I don't think about it. If I don't think about it, it will never happen, but I do think about it. Oh, okay, all right. And then the final thing, I'm cheap. Wait till that trial attorney gets you in that deposition. You'll be thinking cheap. So, okay, so medical emergencies in the dental office, are they rare? Should I worry about them? That's one thing everybody always talks about when you might see an article. They're rare, so don't worry about it. But if you're the person having the medical emergency, you're the dentist having to fight that, you're not thinking rarity at that time. So let's use these numbers right now so we can get a foundation. So let's just say there's 150,000 of us here in America practicing dentistry. On average, we see 10 patients a day, Monday through Friday. So that's a 1.5 million patient visits every day in a dental office. Okay, so keep that number in mind, 1.5, here we go. So that means there's thousands of opportunities for a negative outcome. So, article by Mueller, severe life-threatening, 1 in 30,000 visits. Remember, 1.5 million per day. SCA occurs in 1 in 638,000, another article by Mueller. Then Anders said it's 164 events per 1 million patient visits. Then Atherton said 1 emergency in every basically 3 to 5 practice years. The ADA estimated in 2015 3,000 life-threatening medical emergencies. Then MEP study in 93, 4,300 dentists. 95% encountered at least one. So the key thing here was, after a survey, 7.1 medical emergencies per dentist, 1 every 2 years of practice. Pretty significant. Let me back up right there, okay? A medical emergency other than syncope can be expected. See, that's where we get ourselves in trouble. We depend on the 50% of that study saying, well, only syncope is going to happen. Gosh, I wish I knew about the other 50%. Tell me your crystal ball, because I need to know who to invest in. I mean, I got mad, my friend got mad at me. Why didn't we invest in Moderna last year when they were about $32? Now they're about $600 right now, but oh well. And then the significance. I just said that about 50% is syncope. What about the other 50%? All right? What about the dentists that had to fight angina, cardiac? How about anaphylaxis? How do you feel about treating that on Monday? Epinephrine today? We'll talk about expired drugs in a minute. So again, another article by MEP showing 4.8 medical emergencies per 10 years per dentist. So that works out to be 4.8 medical emergencies. So then I asked a drug kit company, hey, what does that 1706 mean? That was in 2019. That means they had to replace emergency medications in 1,706 dental offices because they use these medications during a medical emergency. So that works out to 6.8 medical emergencies per day. Then Ellen Grimes just gave a talk for Colgate. I asked Ellen, how many people registered? 10,000 hygienists registered for this. And then she says 150,000 emergencies in dental offices every year. Finally, the largest malpractice carrier we have for dentists in the country is MedPro. This lady, Laura Casella, just came out. The occurrence of medical emergency may not be as uncommon as we think. And then just like every 20 seconds, somebody has a heart attack. 45 seconds, someone has a stroke. Every 3 minutes, someone dies from a stroke. Every 3 minutes, someone has a seizure. This could be in our practices. Then, of course, Stan was interviewed one time, dental economics, and he said the training out there is poor. And in reality, most of us are not prepared. So I think I beat that dead horse even further dead by saying these things aren't rare. They're going to happen. You just don't hear about them. Okay, so when an emergency occurs, and it will, you sink to the level of your training. So wherever you're trained, that's how you're going to handle that medical emergency. So let's look at some legal aspects, ramifications, and these will be scattered all throughout my presentation as well, too. So that's a given. We understand. If somebody dies in our office, we know that letter will be in our office probably the next day saying, you are being sued, so get ready. And it's like we didn't know this could happen. All right, we had training in medical schools. We knew it could happen. Our staff asked us to get prepared. I mean, there was a case about 6 years ago where the staff was telling the dentist, hey, her SATs are dropping too low. And he's like, no, they're not. They're fine. I mean, they were below 90. He said, I'm finishing this surgery. Well, she died. Thank you for that wit, all right? It was noted in the deposition, he said, I am finishing this surgery, all right? So I don't know if she was dead on the table and what you know, you're not moving now, so she wasn't feeling anything. So the failure to prepare, plan, communicate, role play, respond, and activate a medical emergency protocol. All of these lead to a compromise in patient safety. But the number one downfall, like I told y'all, is the delay in calling 911. So if I drive that message home today, on Monday you know to call 911 if a patient's not waking up in your office. And someone's got to document that. And we'll talk about the 5R emergency response plan here in just a minute. The bottom line is, it's about building a strong defense for every one of us in this room. Don't let a state board take your license. Say, I did everything I possibly could. I have all of the training right here. I had a bad outcome. I did it right, but I had a bad outcome. You got to be able to empower your staff. There are many cases where dentists panic and they ran out of the room. I get emails. I mean, at these trade shows, that was my number one source. The hygienists and assistants tell me everything. I mean, they would tell me about deaths in their office saying, we hope the state board doesn't find out. What? You don't want the state board not going, they're going to find out. So we all understand in this room the legal obligations rest with us 100%, all right? Even if we have hygienists and assistants, it rests with us. Oh, let me back up. All right, so here are just some of the headlines recently. Not a good headline. And I don't want any of you to make a headline. And I put all this over here because this is where all this information goes now, sadly. All right? Yeah, Dr. Roberson had a death in his office. They weren't prepared. It's all over the internet and social media. You're going to need to hire a crisis management team. No lie. Emergency was going on in the office. They called 911, and they came out and told the parents, and the mother ran back. The dentist, she heard him scream, hey, Google what to do. Google what to do. Oh, my. So the latest headline in July 13th, the mother said, I didn't expect to come out of there without a child. Our biggest nightmare, losing a patient. So, during that medical emergency, the decision we make will affect everything. I like to call it the golden minute. So you got 60 seconds to get it right, or you're going down the wrong pathway. And there's a lot that's got to go on in 60 seconds. But what's the first thing we're doing? Call 911, that's right. So, please Google this when you get the chance. Read it. It's a great read if you want to find out more and more about this. Deadly dentistry. It was done in 2015. There we go. What do you think that 195 means? Deaths in the office. These were medically emergency, unprepared dental offices. Just case after case after case. In fact, in California, a dental anesthesiologist had to sue the board to get the information. You know, it's not like you're going to go out there and share the information with the world. It's just like we're trying to find out what went wrong so we can correct this so it doesn't happen to somebody else. I got a case provided me the other day in a state. The oral surgeon at 10:14 pushed 100 milligrams of propofol on the patient. At 10:15, he pushed 50 milligrams of propofol. That patient died. You know what the state board did? They asked for other records. He was doing the same thing. I'll give you an example. I give my patients 10 milligrams of propofol, maybe 20. Maybe 20. This guy gave 100, then another bolus of 50. That's well beyond an intubating dose. So now you got a patient that's fully apneic. You're trying to support the airway. They lost the airway. Patient died. That's one of those cases that could be preventable. All right, so the RP12 plan, and I'll get a little more further in depth. This is something we developed just trying to prepare your office so that you got everything going on. We're all busy. We got so much going on every day. So I mentioned something about negligence versus gross negligence. I was in Cincinnati, and I gave a 6-hour talk, and then at the end of my lecture, had a gentleman come up to me, said, look, I'm an executive vice president with Cincinnati Financial. Great talk, loved everything you talked about. You need to add something about negligence and gross negligence in there. I said, well, Mike, tell me more about that. What do you mean? He goes, well, if you're going to have an event, we want to be found negligent. But if you're found grossly negligent, the plaintiff attorney can go after everything you own, both business, personal. Don't lose your lake home, your beach house, your mountain home, or whatever because you were found gross negligent. That was a hard pill to swallow. He said, absolutely. He goes, everything's on the table right there. So with dental malpractice carriers, our policies could be 1-3, 2-4, 4-6, or 3-5. A defense team will be hired for you, and then you'll be notified what your policy limits are, and you're responsible for any amount over that limit. Wow, when that letter comes and you read that, that's when it really just sinks. You just got hit in the gut. And don't forget about the surcharge. I talked to a colleague not too long ago. He was telling me about, he had an episode, told the patient, said, there's a good chance you could be numb after this. Well, she was numb. Speaking was part of her job. He was sued to his upper limit, didn't go beyond it. And then he gets a letter saying, okay, your malpractice is going from $8,000 a year to $65,000 a year. All right? And we'll be doing that for the next 5 years. So that's the surcharge. So again, if you have a death in your office, we want to try to prove that we can get you just negligent and get you underneath the policy limits, and then you'll have that surcharge. But you still have your practice, you still have malpractice insurance as well too. And like my colleague said, I couldn't just up and leave and go to another company because they all share this information. So Larry Sangrick again. He's a great guy. In fact, you can hire Larry Sangrick to come to your office, and he'll be there all 8 to 9 hours and just wear you and your staff completely out with drills after drills, checking everything. And I think he charges about $3,000 for that, okay? But he'll fly in and do everything. But Larry is very passionate about this. He contacted the state dental boards. He had a little questionnaire. I mean, wait till you see what I'm about to show you, trying to get information so, again, he can make things better for all of us. So he sent 53 letters because there's some territorial boards as well, too. First mail, no response. Then he sent certified to everybody, no response. Well, Larry said, I'm determined. I want something. So he sent all governors a letter saying, why will your state board not contact me and you appoint them? Well, then he got 38 responses. But then he got halfway responses. But why not all of them? This is it. That's all he asked. He made it so easy, all they had to do was just check the box. And he based it upon the 6 links of survival right there as well, too. So, what document do we have in our office that binds us legally that we have to be prepared for this? I'll give you a hint. We use it every day. Anybody? You're my man now today. I'm going to be calling on you, all right?
You got to have patient consent. You got to have a health form. You got to know what condition your patient is.
That's right. Okay, so it's the package insert on local anesthetics. Every one of us use local anesthetics. But underneath the warning section, that's what it says right there. And that's a medical legal document. We're bound to be ready. So that's it from 2% lidocaine with epi. They got their warning section. Articaine jumped in there with warnings and precautions. And then Articaine went a step further. They put in, they talked about systemic toxicity. They want to make sure you fully understand what you're doing here when you give that injection. They even talked about vasoconstrictor toxicity. I mean, they go well beyond. Then they even tell you how to manage the local anesthetic emergency. All right, here we go. 4% Articaine with epi. Which patient should not receive Articaine? Sulfur, sulfur, sulfite, sulfate. It's the sulfite. And then, of course, 0.5% Marcaine with epi. Oh, I want to just poll everybody. I have a friend that owns a pharmaceutical company. He's looking at creating Marcaine plain in a cartridge. What do y'all think about that? Would y'all use it? I think it'd be great, like whether it be I mean, you have no vasoconstrictor. It's going to be Marcaine plain. But as he told me with the FDA and stuff like that, it's about a 3-year venture to get the NDA formed and all that. Yes, sir. That's right. The Policaine? But that's not bupivacaine. That's right. Bupivacaine gives us the long-acting relief. So the Marcaine with epi, like I use that on all my cases, and they get about 6 hours of post-operative relief before it wears off. So without the epi, you're looking at about 3 or 4 hours of just great post-op analgesia right there. Think about the pregnant patients. You could use that on as well too, because we only have a couple to use right there. So all package inserts say this also. Cardiovascular and respiratory vital signs and the patient's state of consciousness should be monitored after each local anesthetic. So my message to all of you, record vitals. I mean, they're critical. I mean, we have the opportunity to help so many people, not just with what we do in the mouth, but systemic-wise. I know every one of you have had that hypertensive patient that you diagnose undiagnosed hypertension and saved their life. Had a guy in the other day, his blood pressure, diastolics in like 120s. He wants me to do a full mouth extraction on him. I'm like, no, you've got to get on some hypertensive medication, get this under control. He goes, I am under control. I mean, he was getting belligerent. And I said, sir, look, we're here to help you and all that stuff. When you get on your medicine, we get this right, we can get your teeth out. But if you don't record vitals, you never know that, and then you just charge right in there, and now all of a sudden you get either a stroke or a heart attack. So we got to be ready every time we give a local anesthetic. I'll never forget Dr. Michael Reagan, who's also an attorney, saying a local anesthetic injection is a serious surgical intervention. We just don't affect here, we affect the whole body. And again, I think what we do is the greatest thing out there. All right, so what else binds us? Basic life support. When you take BLS, you know that medical emergencies could happen. And the emergency drug kit as well. So with our defense team, it's all about the documentation. There was a case that involved several doctors. The attorney said, I want to go to trial, and I want to go for $30 million. They, of course, well beyond your policy limits, right? And they said the medical care was done. They had all their documentation. They did everything right. The defense team went in, fought them, won it. That's what we want. So the RP12 plan, it's about protecting and preparing your practice. So if you don't do sedation, here you go. If you've got these 12 items here, and the ALSD, ALSDH, and DA are brand new programs that complement BLS, and we'll briefly talk about them shortly. So everybody in the office will be ready. Now, if you do sedation, just add one more, capnography. But please have the monitors on the patient. That case I was telling you about, the coroner with the CRNA, it's claimed that the surgeon pushed 200 milligrams of propofol initially. 200. And of all people to have as a coroner, a CRNA, not going to be a good situation. And they said he didn't have monitors on the patient. That's one of those things that make you want to go, I wish I could plug that into my videos. All right. So RP12 is an insurance policy, basically. I try to work up all the various prices for everything. So total cost is about $2,500. So we buy a car, we spend about $1,500 a year on it, on insurance. We have a homeowner's house, maybe worth $500,000, we spend maybe $4,000 on that. So why wouldn't we want to risk-proof our livelihood? Give them a strong case. Okay, so let's talk about the red E zone. Gentlemen, behind the curtain, y'all ready? We're going to watch a little video. If it comes on. Is everybody from Nevada here, or everybody just fly in? Or okay. I know in Nevada they mandate AEDs here and all that as well. All right, there's the sound. There we go. All right.
You doing all right?
It's a little hot in here.
A little hot? Mm-hmm. Do you mind checking the air conditioner? Seems a little hot in here. Check that. Go ahead and open.
You should open your mouth back up. Doctor?
Go ahead and open.
I need some insulin.
Charlie? Charlie? Go get some oxygen.
I don't think he's okay at all.
Charlie? 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 Where's the tubing? There's some tubing. Go get the tubing. Charlie?
Come on.
Charlie? Charlie? Come on.
Right. Can you hold it?
Pull that over his face.
Come on.
Do we have another tank?
That's the one we have.
Great, this is empty. Call for help. Call an ambulance. 911!
Okay, yes, Mr. Jones. We have you down for 3:15 on Wednesday. Wednesday the 16th, July 16th. Okay, thank you. Make sure you bring your insurance card for verification. Thank you. Okay, we'll see you then. Bye-bye.
The patient's not responding. You have to call an ambulance
What?
right away.
Oh my God. Hello?
Charlie. Just get him some oxygen here. I think we'll be at home. Charlie? Charlie? Come on, Charlie? Charlie?
Doc, do you have any information whatsoever on this gentleman? Any complaints?
Just
doing a filling. What kind of medications did you give him?
Just my wife.
How long was it before when you became aware he was like this? Or when's the last time you actually talked to him?
About 7 8 minutes ago.
Okay, so he was talking to you at the 8-minute mark ago, is that correct?
Where we're just working on his feet.
Was he talking? Was he responding, moving his eyes?
What he's done is he's talked to his medical director, and because of the length of time that he's been down with no response, the medical director has authorized him to stop.
Anybody know where family's at or anything?
Okay, that's good. Y'all can stop it.
Hey, Doc, I'd be happy to find you guys some CPR classes or something.
Okay, you can see how fast 4 minutes goes. All right, a lot of issues in that treatment of that patient. Just regular patient at the office, and then like that went down. How many times did you say Charlie? I don't know why. I never get tired of watching that video. I've been showing it for 15 years, but 18 times. What medical emergency was that? Who said that? My man. You're right on. All right. So I started adding this slide here because nobody could get it right. And that was always concerning to me because, you know, that's a video right now that's made, but they did a really good job acting that. This could happen Monday in our office. So Charlie didn't feel good. All of a sudden loss of consciousness. No pulse, no breathing. Classic sudden cardiac arrest. I sort of hinted it to y'all when I said, we're in Nevada, so they have AEDs. That's the only treatment. Now, I used to say, okay, what drug do we give for that? And everybody, epinephrine. No. Epinephrine's going to do you no good here. It's not the same as a heart attack. All right? The heart attack patient is going to have a crushing elephant on his chest. All right? You're given nitro. Then the heart attack patient could then pass out because of pulseless V-tach or pulseless V-fib. So they went from angina, heart attack, to cardiac arrest. That's where you do the drug shock protocol in ACLS. SCA is an electrical problem. Same thing, how many times our computers just like, oh, they're frozen up, you got to reboot. Same thing, the heart's just quivering so hard. Just got to get rebooted. But the heart attack is the plumbing problem. And by the way, 7,000 kids die every year in America from sudden cardiac arrest. You can make a difference with a defibrillator. So let's just look at all of the many problems. I mean, this goes against everything we just talked about, the 6 links of survival. Of course, there was no defibrillator, but he didn't know. So let's talk about 2 cases. 1 case, 2 brothers. Patient in their mid-40s, getting a root canal. Sudden cardiac arrest. They didn't do BLS or CPR. The ambulance got there and they saw nothing going on. By the way, when EMS gets to your office, look busy. Make sure you're doing something. Because they're going, yes, sir.
Shouldn't you have the staff member waiting outside, waving them down, directing them exactly where they need to go? I mean, doesn't that make sense?
Absolutely, and we're getting to that. You've been to my lecture then? No, you're right, and that's the 5R plan that I'm going to show you in just a minute. And we got Rover 1 and Rover 2, and those are your front office personnel, and they're critical for all of this, okay? But one of them, yes, sir, is directing that EMS and guiding them through your office so that they can get to that patient, okay? Yeah, great comment right there. So the lady died. They were in the deposition. the attorney said, I'm taking you to court, because he knew the situation. It was totally unprepared, all right? He goes, I'm asking for $25 million. The two brothers settled for $8.4 million. Now everyone get this. Their policy limit was 2.4. So the insurance paid $2 million for each brother. So that's $4 million, leaving $4.4 million left for the rest of your life paying to that family. Now, I never found out, did the state board take their license? Because if they didn't, if they did, what are they doing to pay that? Because that attorney's going to get paid. That family will get paid. That was such a significant case. Then here's a medical emergency prepared office in a state that did not mandate AEDs. The dentist bought an AED. He had the training. Similar situation. Is that root canal thing? Lady had a sudden cardiac arrest. He recognized it. They grabbed the AED, put the pads on, shock advised, shocked. Everybody went home that day. No lawsuit. The tale of two cities. So one person dies every 5.25 seconds of a sudden cardiac arrest. So basically, about 1,000 patients every day in America. And the only treatment is an AED. So in Nevada, we have that. There's a new AED coming out. His name is Elliot, being made by a company called Heart Hero. The guy's name is Gary Montague that runs it. No lie, it's the size of 2 cell phones. And when you pull open the drawer to grab the pads, it activates a GPS signal to call 911 and your location. So he's already helping you in the game. $500. Now, it's all around the world except one country. Take a guess. Yeah. It's got to go through FDA approval, you know. I think the reason being is, you know, the big boys are very concerned about that, but everybody's just, I know a lot of people that teach BLS, their individual companies are trying to get on the vendor list as soon as it becomes available, because this is something you can keep at home. All right, so the golden minute, we don't want to be like that. That's called the ostrich approach. Staying calm in an emergency. So now let's go through some patient rescue strategies with these little acronyms that I put in there. RPABDEF, CARE, CANAL, DOMS 24, and the 5R ERP plan, sir, that you talked about with those. All right, so base management of medical emergencies. This is the RPABCDEF. Now, let's break them down individually. So we recognize we call for help 911. All right, that's the first thing we're doing. And then we start getting everything there. All right, the emergency response plan has been activated. And if you have rehearsed, everybody knows their role. The position, make sure the patient is comfortable. Make sure you're in the right position, and we'll get into that in a second. Airway, assess it. Know how to treat an obstructed airway. Breathing, apply that oxygen. Circulation, diagnosis, which medical emergency. And then, of course, the emergency itself, and then follow up. Okay, if you have an event at your office and you've done everything right and they transport them to the hospital, please make sure you call the family, see how they're doing. Make that empathetic move for the best. Or CARE. Remember this acronym. Call 911, airway, airway, airway. R is for react, respond, retrieve, record, and then E is for your emergency stuff. You either care or you don't care. If you care, the patient has a chance to survive. And if you don't care, they don't. We showed the example of 195. I'd have to say they don't care. It's all about the care you give. The DOMS 24. These are the 24 medical emergencies you ought to go back Monday and talk to your staff about. Hey, we got this, right? We can do all this, right? Todd Goldman has got the DOMS 24 monthly mock drill program on his website. but it's also part of the ALSD stuff as well we'll get into in just a minute. And it's really cool stuff. Todd's going to give you the opportunity to either do all 24 at one time, or if you want to spread it out over a 24-month period, but you're getting one medical emergency, and I'm going to show you a little snippet of one of those emergencies in just a second. So it's just syncope, right? Are we sure about that? So I told you in the very beginning when we were building our foundation, 50% of emergencies occur in the dental office are syncope. So as soon as syncope happens, what position do we put our patients in? Supine with legs slightly elevated. If you remember, he put Charlie straight up. You don't want to do that. So let's look at syncope gone bad. 15-year-old went in for extraction of a molar with local anesthetic, placed in the upright position and given an inferior alveolar nerve block. It was noted his eyes rolled back in his head. Oxygen and ammonia were brought, had a mild seizure. They activated their emergency response plan. The ambulance happened to arrive in 6 minutes. So everything's going right. When the EMS got there, note everybody, they moved the patient to supine. Now the patient is in cardiac arrest. Now they do the ACLS protocol. So the cardiac arrest was either VFib or VTAC, all right? The first round was unsuccessful. Second round was successful. However, he had myocardial damage, but due to the lack of oxygen, wound up with permanent neurological damage. So this is some pearls with syncope. It's the most common medical emergency. When not managed correctly, this is the only reason for a fatal outcome. We're responsible for that. It's easy to manage if we don't panic. So my hint to everybody is, just place them in a slight supine position when you're giving your local anesthetic. There's a great chance you might prevent syncope already. You may already be doing that already. So don't treat it as a benign situation. Guess what? They're the same thing, except in one wakes up. All right, I wrote an article about the syncopal trance, where we can get caught in. These are just some of the various examples of somebody having syncope in your office. And when you notice that in your medical history, it's like, yeah, I've been fainting a lot. Well, I like to think there's something cardiac possibly going on right there. Let's get you to your cardiologist for a workup. But look at all of the things that could be syncope. So for us as dentists, here's our top 9 for differential diagnosis of unconsciousness. Things to think about. Things to go back to the staff and say, okay, how do we treat this? How do we treat this right in 60 seconds? We got this, right? It's all we. Now, I also like to put in this about my stress, anxiety, medical emergencies. We call stress because of what we do, all right? So there could be hypertension, hyperventilation, or there could be asthma or angina. There could be seizures or syncope. Let me just go through that. Okay, so BASES, another one of those acronyms I told you about. Basic life support for everybody in the office. I recommend people up front too. Advanced training for the staff. You're doing that today. STAT 911, emergency equipment, and then simulations or mock emergency drills with repetition. I like how Dwayne Tinker, known as the tooth cop or the compliance cop, he's got a great business. He was talking one time with a podcast on medical emergencies. He said, we must practice until we never fail. So if we can understand the recognition, rescue, and resilience of the deteriorating patient, we can prevent these failures. Crisis resource management. You know, many of us that flew here, every one of our pilots undergo crisis resource management. They're in a simulator every 3 months, all right? Thank goodness, right? So use cognitive aids that will help you during this stressful event. That's why I like medical emergency manuals and checklists. Mr. Goldman will be having laminated algorithms that are 9 by 12 in size. Just grab and go during that medical emergency. So again, there's the domes 24. Don't we wish we had a crystal ball? It's going to happen in 2 days. I'm going to be ready for that. Oh, yeah. So I spoke one time at the Mississippi Dental Hygiene Association. There was 250 dentists, hygienists there. They had no idea I was walking in with a survey. And I asked them, and I said, I don't want your name. I don't want your city where you practice. I don't want the name of your practice, nor do I want the name of your dentist. And just look at the stuff they told me. So now let's talk about the CANAL acronym. C for cardiac arrest. That could be any of these listed here. Chest pain, myocardial infarction, dysrhythmia, sudden cardiac arrest, VFib. A, airway. Foreign body, bronchospasm, laryngospasm, hyperventilation or aspiration. N, neurological. Seizures, TIA, stroke, panic attack, anxiety. A for allergy and drug reaction, latex, anaphylaxis, allergic reaction, epi, benzo, local overdose, narcotic overdose. And then finally, L, loss of consciousness. Did I go too fast? Anybody taking pictures? Y'all need me to back up or anything? All right, so here's that copy of that monthly mock drill, all right? So we want to know the fundamentals of the office, drill preparation, conducting the drill, documenting the drill. Do this every month, and then put it in a binder. So let's just pick on anaphylaxis, okay? So there's a disclaimer. That's everything you'll get in the mock drill that you'll cover with you and your team. I strongly recommend naming the dental assistant in your office the patient safety officer or coordinator. Give this to her or him and say, here is your new role. Make it shine for us. Call this mock drill every month. Further on how to use it, a suggested training plan if you want to do it a certain way like that, or do all 24. So again, we do the EMS rehearsal. Call 911 instructions. Please make sure that, of course, if the patient is swelling, we know more than likely that's anaphylaxis, that your front office is telling the person, the dispatcher, we have an anaphylactic reaction in Dr. Roberson's office, 811 South 28th Avenue. Do not hang up, but make sure they tell her anaphylaxis. Therefore, that team knows to get here as soon as possible. So, as the gentleman just alluded earlier about, hey, I need front office out in the front. Here's your 5R plan right here. The dentist is the reactor. The dental assistant next to you is the very first responder. He or she is going to be right there with you when that patient goes down. 2 is better than 1. The hygienist will be the retriever. The front office personnel will be rover 1, rover 2. So there's our duty as a team leader. We must stay calm. We must stay in control. And it goes back to the ABCs I was talking about. All of this is right here. And we got to be able to accept criticism or advice from our team members. We got somebody dying here possibly. The dental assistant, they're right there with you and the patient. Now, should the dentist panic and leave, they now become the team leader. And that has happened many a time. Team member 3, the dental hygienist, the retriever. They get everything. The emergency or code blue or I need help, whatever. That emergency response plan is activated right then, and people should be rolling to their duties. And the dental hygienist is getting you everything you need. Remember the video, the 4 minutes. That's all we got. Now, Gary Montague with Elliott and Heart Hero says 3 minutes. And the American Cardiology Association is starting to say the same thing. 3 minutes to shock somebody. And every minute we wait on a sudden cardiac arrest, we lose 10% survivability. So there we are at their rover 1 and 2. So 1 is making the phone call, stays on with the phone until the dispatcher tells you to hang up, okay? Then rover 1's out there waiting on the ambulance to get in. Rover 2 is calming everybody down and then going to the back and start documenting. Rover 2 is critical for all of us, all right? So, again, just reinforcement of the basic management, the drill preparation, how to manage it, how to conduct a drill, and then post-drill, when you do your debrief. Okay, what did we do right? What did we do wrong? Let's practice, practice, practice until we don't fail. So in the 911 call statistics, okay, good. You activated it 30 seconds, within a minute. 10.6 seconds. This is where they come up that it's going to take an ambulance roughly 11 minutes in urban areas to get to your office. So we already saw the video for 4 minutes, and we already heard that possibly 3 minutes they could be dead. So that's why you got to have an AED in your office. It's all about the ready zone. So the golden minute again, these three, remember those. So on the first minute, the first 60 seconds, here's everything we need to be doing. The 5R plan gets activated. Airway, 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 911's been called. And I put in there, this is the longest 10 minutes of your life. I talked to a dentist one time, he had a medical emergency. It took 18 minutes to get the ambulance there. The patient survived and all that. He did everything right. He said, I swear it felt like 5 hours. I kept saying, when are they getting here? So from minute 1 to 3, we're checking for the response. Go for the carotid artery so you can get that feel right there. I mean, this is our basic life support right here. We all know this. But it's just good to go over it with your staff as well. So you just keep repeating everything after minute 3 until EMS gets there. So I said something earlier about do something versus nothing. In a southeastern state, they had a medical emergency. When the EMS got there, the dentist and the staff were huddled like this, all praying. Patient in the chair, dead as could be. That's not what you want to be doing, all right? They didn't know what to do. They had anxiety. They had performance anxiety, stage fright. They choked. And if you prepare yourself, you can get over that hump right there. Like I said, this is no longer about who is right, because I said, if you take advice from your staff, don't take it personally. They say, hey, Dr. Roberson, what about this? What about that? They're trying to help you just as much as you're trying to help yourself. It's about what is right for the patient. Some more of the legal aspects. Now, when I do surgery, after we prep all of our patients, we actually shield their eyes as well, too. I wear a headlight during surgery. We've never had any type of ocular infection or injury. But in this case here, a child was getting her teeth cleaned, and the scaler was dropped by the hygienist and blinded the eye. And I've heard from other people in malpractice carriers, they'd much rather have something that ended rather than lingers for life, like blindness or a stroke that requires long-term care. All right, I know the writing on this is very small. So a 67-year-old lady came in to the general dentist. She filled out the health history. She was there for the very first time to get a cleaning. Next to heart disease, she just checked yes and just scribbled IE. And then she was seen by the hygienist, had her teeth cleaned and all that as well. And then she went home. By day 3 or 4, she started feeling really bad, shortness of breath, chest started to hurt. She was admitted to the hospital. She had infective endocarditis. Okay, so nobody picked up what IE meant, all right? We got a lot of acronyms out there, so we got to remember all of that. She should have had some antibiotics ahead of time, all right? So she got a PICC line for 6 weeks. So the patient retained an attorney, as you can imagine, sued both the doctor and the dentist. What liability do we call that? Vicarious liability. So your hygienist does something wrong and she gets sued, so will you. So you have vicarious liability. However, they took a payout, the patient and their family, and I applaud the malpractice defense attorneys. They had them sign a gag order, an NDA. They could never, ever talk about this case. They could never, ever post anything on social media. Kudos to that malpractice carrier. Outstanding. Because I just showed you on the very slide about, hey, Google, what to do right before. Say, don't get in social media. They took their money and ran. So again, legal downfalls, it's all about the strong defense. Deadly dentistry again. The Blue Ribbon panel in Texas went back and looked at every one of those deaths. Emergency failures in every single case. So again, I'm back to that failure thing. So that's what I'm preaching here today about, get rid of the failures. Their critical statement was, it boils down to poor performance during an emergency. So which treatments have the highest incidence of medical emergencies? Extractions and root canals. By the way, which treatments have the highest incidence of lawsuits? Extractions, root canals. One time I gave this talk and I had a dentist come up to me at the end and said, I'm done with both of them. If it's going to reduce my chance, I'm done. I don't need it anymore. And staff training. There was a case where a child died one time and the plaintiff attorney had the dental assistant in a deposition, and she is one responsible for the care of the children after sedation. And he said, what's this? And she said, I don't know. It was a stethoscope. The malpractice executive who was there already had a check made for $1 million. He slid the check over to the attorney and said, let's go ahead and close this out right now. And I guess the guy just felt good and said, you know what, instead of waiting 34 months to get to jury trial, sure, I'll take the $1 million instead of going, because that probably could have gone for much more. So what is your medical emergency plan? Are we sharp bait? Are we an MEU? So this is taken right out of malpractice companies that I've looked over their claims reports. The big issues are always these: practice procedures and emergency protocols. And everything we're learning today is able to get rid of that. And then, then we get to not have to go to that deposition and start to answer all these questions, because you'll get interrogatory questions. You'll get these letters start coming to your office, and you got to start filling all this out. It's taking time away from your practice, and it's adding stress to your life. I put 43 questions on there because Dick Heckey, who used to be the executive director for the Dental Board Association, works with AFTO now, and he said, here are about 43 questions that plaintiff attorneys would ask you and your staff. And remember, you and your staff won't be in the room together, and you can't tell your staff what to say. So we'll just go through all that. That's all semantics right there. I don't want to sit there and go through every single question. But good gracious, you can see hours and hours of deposition right there. And they're filming you. They got a ring light on you. So the most frequent claims just from one malpractice carrier right here are these. I do see syncope in there, but others. Empower your staff. When the ship is sinking, promote everybody to captain. It's all about everybody. So there's ALSDA, and that's what your dental assistants will get through Mr. Goldman's company. 5 modules on those different topics. Then they get the 24 monthly mock drills with that. And then you get a hands-on instructional guide that tells you everything you got to do as a team. Talking about airway and all this stuff as well. But somebody's got to make everybody do it. That's why I said make the dental assistant that person. Same thing for the hygienist. They get a few more because they're, wherever you work, or your hygienist allowed to give local anesthesia? I'm in Mississippi. We don't allow it yet. I think 7 states still say no to it. And then we met with the Dental Assistant National Board, and they have a team of dental assistants on their executive board, and for general dentists. And they loved ALSDA, but the dentists were all raising their hand. What about something for us? So ALSD was created after that meeting. And that's everything you get right there with your 9 online modules. You get into all of the various disease states. And this complements BLS. You're just building that strong defense. This is the copy of the instructional guide you'll get. And then DOMES is a new project coming out. It's a video introduction that tells you what DOMES is, the Dental Office Medical Emergency Simulations. A video of a mock drill, how to do it right, how to do it wrong, and then 24 individual videos of the DOMES 24 emergencies. All right, never drive a patient. Here's a case that a dental assistant sent. She said the doctor gave an injection of local anesthetic. Then all of a sudden the patient immediately started having a bad reaction, gasping for breath. The dentist went out, left him with this brand new hired dental assistant. She panicked and drove the patient to the hospital. I don't know the outcome, but y'all think about it a second. Had she been in a wreck and that patient died, negligent or gross negligent? What do you think? Gross. I wish I made all these stories up. I mean, there's just more and more like this. Endodontist was treating a patient one time in a hurry, didn't review the chart well, threw on some gloves, went in there, started messing with the patient, and she said, wait, I don't feel good. Wait. She had anaphylaxis to latex gloves. He had on latex gloves. He panicked, put the patient in the vehicle, drove to an oral surgeon's office. They were closed. Then he drove to another oral surgeon's office. He had to stop at a red light to stop traffic so he could drive to get there. Now, fortunately, she wound up having a delayed type anaphylaxis, not a full-blown type 1 that we'll learn about in just a second. Again, negligent or gross, he would have lost everything. But they got there, and I disagree with what I heard that the other orals, they got an IV on her, gave her some epi, sent her home. I would have admitted her to the hospital, just be on the safe side. You just had an anaphylactic reaction. All right, so the emergency drug kit. It's essential for our setting. There was a study done, an article done many years ago, and it showed that all dentists polled, 84% had a drug kit. I want to try to believe that, okay, those that didn't have it, the 16% had emergency medications, they just didn't call it a kit. I don't know why it wasn't 100%. Always know where that is. Oxygen. This costs you about $200 maybe at the most. I had a dentist tell me one day, I don't believe in oxygen as far as a portable one. I said, well, what are you going to do if someone has a problem in the reception area? He goes, oh, I got that figured out. I said, well, tell me how. He goes, I went and bought a bunch of nasal cannulas, and I cut them all up, and I duct taped them so they stretch all the way from my back to my front. Now, I'm here to tell you, everybody, there's zero oxygen getting to that patient. I bet he spent $500 on nasal cannulas. All right, so epinephrine. Not all EMS carry epinephrine, and I've got some instructions and some homework for you for Monday about this. This is very important for you to check this out with your local EMS. And remember, 35% of all victims of anaphylaxis require a second dose. So I showed everything up here. I'm not a fan of the vials because you're in a panic situation right now. You got a person swelling. Anaphylaxis is one of those 3-minute medical emergencies. I say sudden cardiac arrest, anaphylaxis, foreign body obstruction. You got 3 minutes to save a patient's life. You got to inject. I like the auto injector, okay? Now, I like AviQ. When you pop that cap off, guess what it does? It does a voice recording of instructions to you. It reminds you to call 911. It tells you where to inject in the anterolateral thigh area. So you got that for the adult. You got that for the child. And then AviQ came out with the infant dose, 16 to 33 pound. So the hypersensitivity reactions, the type 1 anaphylaxis, angioedema, urticaria, those are immediate treatments. So on the allergic reaction, the mild is a rash and an itch. Urticaria is the whelps and all that. Just keep that in the back of your mind. If somebody starts whelping up on you, you got to start thinking, am I about to have a full-blown anaphylaxis? Another one of my acronyms, DEAD. So during anaphylaxis, you're given these drugs. Never, ever hold back on giving epinephrine. It's the life-saving drug for anaphylaxis. Then diphenhydramine for the histamine release, albuterol, so you get the beta-2 sympathomimetic response, and then dexamethasone to help with inflammation and swelling. 911 should have already been called. Okay, here's what I'm talking about, your homework, all right? On Monday, have someone call, talk to your local EMS. Find out who is coming. Is it an EMR? Or is it an EMT basic? Or is it a paramedic? A paramedic can give epinephrine. Now, if it's an EMT basic, they may not be able to give it. This is why I've had people before, and the deadly misconceptions or excuses, I don't believe in carrying emergency drugs, all right? If you're dependent on them, they may not be able to give epinephrine, nor they may not have it in their truck. So Monday is your homework. Find out what it is. I also like for dentists to know how to place an LMA, all right? I just wish, you're not going to be able to intubate anybody. I wish BLS would introduce LMA airway adjuncts. They're just so easy to place, and you can maintain the airway before the professionals get there. Okay, so diphenhydramine for allergic reaction. You got the capsules, then you got the injectable. Aspirin. You know, it used to be Mona. Nobody's got morphine in their office, or do y'all? All right. I've been practicing 24 years. I never had morphine once in my office. So Nona, nitrous, oxygen, nitroglycerin, and aspirin. And make sure they chew it up and swallow in front of you. Remember, the heart attack, they're still responsive. Now, very important thing, all right, now I'm getting granular on you. I'm getting to the fine minutia. But again, if something were to happen in your office, I don't want this to fall back on you because these attorneys hire everybody to find out everything about you, all right? So there is an issue about taking ibuprofen with aspirin. It can affect the cardioprotective aspect of aspirin. So here's the bottom line. You can either do at least 30 minutes after aspirin or 8 hours before aspirin ingestion. All right, it's hard enough for our patients to remember many of our instructions. So I'm not going with this one. I'm just going to tell Ms. Jones, say, look, take your aspirin at 7 and then take some ibuprofen at 8. Should you do like an extraction or implant and you don't want to prescribe narcotics, just keep that in the back of your mind and even write that down. Tell the patient to take their aspirin here, the ibuprofen here. You're good to go. Again, I'm just being real granular. Albuterol, please make sure you have that. I do case reviews. They'll pay me to go in and look at a case, and I'll give them ideas and thoughts on how the defense team could do well in the case. I got a phone call about a dentist that had an asthmatic attack in their office. They didn't have albuterol. I said, look, there's no need for me to review this. There's no need for y'all to pay this. I'm just going to tell you up front, do everything you can to just go ahead and say, look, we'll write a check for $1 million or whatever his policy is. Just try to get it resolved. There was no need for me to review that. Glucose. Remember, for treatment of hypoglycemia while awake, if they go unresponsive on you, there's glucagon right there. Just give that whole syringe right there, right in the thigh. So I carry in my kit both Instaglucose and glucagon. Don't put Instaglucose in an unconscious patient because now you could get an aspiration. Now you got another issue to deal with. Nitroglycerin. Available in spray or tablets. I like the tablets, all right? The reason being, I can see it go in the mouth. I can see it being dissolved. It's underneath the tongue. The spray, it's chaotic, all right? And so you're trying to spray, and for any of us that have spray cologne or the women, you know, those atomizers can clog. So how do you know you're, first of all, getting the spray in there, okay? That's why I like the tablets. And if you open up the tablets, they're no longer good after 12 weeks. They're $8 for 25. And the spray can be very expensive. Now, very important about ED drugs, all right? So that we've got these right here on the market. It's good to add to that health history. Do you take any of the following? And see, here's the other issue about taking, you know, I put this in here on patients that are taking nitroglycerin because they have all various different names. Like I had a lady in the other day in my office, and she's on isosorbide. And I said, okay, do you take that every day? She goes, I take that every day. I said, are you still having any chest pains? I am. Well, what do you take for that? She goes, I take supplemental nitroglycerin. That's a patient I don't want to treat in my office till that gets corrected. So again, I'm preventing because I went deep into her history about that. Because I put on there, I'm on that ISO something. Oh, okay. Are you? That must be a supplement, huh? All right. So what causes erectile dysfunction? All of these right here. Remember that nitroglycerin is an absolute contraindication to a patient on ED if they have chest pain. So what do you need to do? If they're on that and say, hey, look, we're going to be doing a lot in your mouth. I'd like for you, and this could be an uncomfortable situation. If possible, I'd like for you to hold that medication for about 48 hours. Then it's completely cleared. So should I give an expired drug? I was at a conference in Scottsdale, and a gentleman raised his hand and said, look, I just got back, and they said it'd be okay for me to give an expired drug. And I said, they gave you some wrong advice. Don't do that. As soon as I got home, I called MedPro, got the head risk manager on there. His exact words were, res ipsa liquidator, which means the thing speaks for itself. The facts are so obvious, we wouldn't be able to do anything about it. He said, you put yourself in a unique situation, and we're not going to be able to overcome it in court. So, Dr. Roberson has a patient in his office. Patient has anaphylaxis. Then all of a sudden, Jennifer, my assistant, said, hey, Dr. Roberson, that epinephrine's expired. Give it to me anyway. I give it, the patient dies. Well, the plaintiff attorney's going to go in there and say, if Dr. Roberson had had in-date epinephrine, jury, my client would be alive today to enjoy her grandchildren. It's over. And then I called a drug kit company and they said, we'll never send you an expired drug. A friend of mine does anesthesia reviews, and he's done hundreds of them. He told me in this one state that he has reviewed, about 90% have expired drugs pre-COVID. Somebody needs to be on automatic refill system. So, emergency medical kit. Great company right here. Protected Dental. Awesome people. Cool kits they have developed. So they're all about patient safety. So do you need a new kit or do you already own a kit? That's what they call their EMK takeover. You may not be happy with the company you're using. This company sends you your drugs 30 days before the expiration. You won't get them 90 to 120 days like, wait, I just paid $500-something for this, and the drugs aren't expired for another 4 months. So they have a kit for everybody. And that shows you everything that's in it per adult or geriatric or pediatric. They have what's called their onboard existing med system. So you put on there what you have in your kit, and you just follow the prompts, and then they can take over your system for you. So there's their auto replenishment program. This company is based in Fort Worth, Texas. They're just awesome people to work with. And they sell it individual as well. And there's the CEO and owner, Scott Sankry. He wants to hear from dentists. He goes, I'm all about making the best emergency medical kit there is. All right, so here's a slide you want to take a picture of. It just shows the various emergency situations that you'll be using your emergency kit with. I tried just to cut it down to where it's just a few words each. So right now, you know, we've done everything we can with the opioid crisis. And by the way, we didn't cause that. The dentist didn't cause that. I've heard that before over and over. There's plenty of pain management docs out there, but we didn't do this, all right? But 255 Americans are now dying every day, all right? And naloxone is the only treatment for it. So that same drug kit company also has the nasal spray. But remember, when you open that up to spray in the nose, you don't want to do that once to make sure it's working, because there goes your Narcan. HAE, anybody know what that is? How are we doing? Everybody good? I know I've overran lunch, haven't I? All right. They took away my time, though. They didn't let me start at 10:30, okay? I mean, I love speaking this stuff. I just love it. All right, so HAE, hereditary angioedema, all right? It's critical to us because it affects the face and the airway. So they're deficient in a certain protein, C1 inhibitor. They can occur spontaneously without any reason, but one of the triggers is dental procedures. So I would add to my medical history, have you ever had any swelling after routine dental treatment that occurred several days after the treatment? So what medications have known to be more frequently associated with HAE? My man, yes sir. Up to 40%. So they're the leading cause right there of drug-induced angioedema. So we got hereditary edema, we got drug-induced edema, then we got allergic angioedema or idiopathic angioedema. So up to 40% of all emergency visits are due to ACE inhibitors. So that's before the HAE attack, that's afterwards. There's a lady also after an HAE attack, and there's her autopsy. 2 teeth were taken out. And y'all check this out. Okay, so now you're looking at laryngeal edema. If you've never seen it, there it is right there. That should be flat like that. Okay, some of the key points right here. It can occur hours after the treatment or days after the treatment. So if you were to get a phone call late in the evening, hey, I've got some swelling going on with my throat and all this stuff. Hey, are you on an ACE inhibitor? But it's not just the ACE inhibitors, that's the primary. So as I said, there's 3 types of angioedema. Was everybody aware of this? Recognize the triggers. There we are, dead center. All of us are doing surgeries, okay? The ACE inhibitor, drug-induced angio, affects the lips, tongue, face, and airway. See, angioedema can also affect legs, the abdomen, genitals, but this is all this affects. So early signs of laryngeal edema may include hoarseness or stridor, and that's in 10% of the cases. And there are fatalities due to this. Now, the good thing about the time course, Each episode follows a predictable time course of 2 to 5 days in duration. So when a patient is put on an ACE inhibitor, we'll discover this ACE inhibitor angioedema within the first week. But what if they went to their doctor on Monday and then had a procedure done on Wednesday, and on Monday they got their ACE inhibitor for the first time, and then you did a procedure that happened to trigger it? It's coincidental, but it triggered it. That's what we got to be thinking about. Hey, Dr. Roberson, I'm not feeling good. You know, I've got some swelling going on. I feel like it's very hard to swallow. I'll meet you at the emergency department. So here are some of the other drugs that are implicated. The DPP-4s, they're used for diabetes. The renin inhibitors, also used for hypertension. The ARNIs, which is also used for heart failure and a reduced ejection fraction. And the ARBs. I'm getting granular on you. In the event you see that and you look at all the medications, this is a little bit of the pharmacology aspect as well, too. So, all right, let's move on. Patient comes in your office and they say they're on one of these medications. Any idea what it is? What's the disease state for those drugs? HAE. This is the one you want to be concerned about. Let's back up. Patients are taking this as injectables so that they can control the swelling. This is where you want to get that consult with their immunologist or endocrinologist that's handling this. Hey, I've got to do this and this and this. Therefore, they can give them a loading dose and we can be prepared for something. I'm going to run through these. You've already seen there's no need to see this. These are all the treatments that they'll get. Now, some of them can be quite involved, like when the patient has it, they're going to have to mix up the solution and actually give it to themselves. I don't see that being successful. What a great name, Haegarda, HAE right there. See, that was the trigger right there. Now, Orladeyo is finally, because a company said, look, we're tired of everybody having to get injections for this stuff because it's very expensive. And it's a capsule. It works by suppressing kallikrein. So therefore, that's the precursor of bradykinin, so we don't get all of the swelling and inflammation from that triggers an attack. Take a guess how expensive this is. 15? $485,000 a year. So, and there's a lot of new drugs out there, y'all. So, patient red flags. All right. Greater than 65, just keep that in the back of your mind. We don't metabolize drugs near as easy as we did in our 30s or 40s, and more than likely to have an ADR, acute drug reaction. When was your last visit? Oh, it's been years. Well, it'd be nice to know what is a CBC or elevated liver enzymes, KIM7, PSA. Hypertension. Any patient on 3 drugs or more for hypertension, in my opinion, that's a red flag. Why are you on that many drugs? I know y'all have seen it. They come in and you start counting. It's like, wait, you're on 6 medications for hypertension. So there's the various classifications right now, stage 1, 2, and 3. Stage 1, minimal risk. Stage 2, why? I might want to find out how come the blood pressure is not under control. Stage 3, definitely don't treat. That's like the guy I gave you the example of. And by the way, we actually called a physician's office to see him right there, and the nurse, and they're great. They said, send him right on. We'll see him right now. And then the nurse said, let me speak to the patient. He got upset with the patient and said, I'm not coming. Well, we documented all of that in our chart. We went beyond the call of duty. So some important indicators, the pulse rate, systolic and diastolic. So have you ever heard of RPP, rate pressure product? It can be linked to cardiovascular events. It can give you a little tidbit in the mind saying, might not be the right patient to treat today just yet. So it's the heart rate times systolic blood pressure. And it's a great parameter for cardiovascular events. It's a red flag if it's above. So any total greater than 10,000 means that patient has an increased risk of heart disease. Basically, RPP is the oxygen demand on the heart. So here's an example. A person's in our office, they have high blood pressure, 140/90. They have a heart rate of 85. So 85 times 140 is almost 12,000. That's above 10,000. Why is it above 10,000? That's the baseline. Red flag. Whereas you got somebody that comes in that's fit, they're 5,000. So just a quick little way to keep a calculator in the consult room, figure it up real quick. Anything over 10,000 is of concern, especially if they have a history of these four. A potential heart attack in your office right there. So again, we're trying to prevent something. The pulse pressure. That's the difference between systolic and diastolic. The normal range is 40 to 60. So if you have a low pulse pressure, 40 or less, that could be indicative of heart failure, red flag. Above 60, indicative of increased risk for heart attack, red flag. So again, those are some important indicators. Your pulse oximeter, they're $30 now on Amazon. All right, look at the oxygen saturation rate. Why, if it's under 93, is that happening? So do you want to make a consult? Wouldn't hurt. All right, they're on room air and they're doing 90 to 93. And then the physician may say, just add some supplemental oxygen. The pulse also tells us the pulse rate. Why are they tachycardic in my office? So if the patient's heart is already compromised, why is it beating away like that? That could be a red flag. We know about the accentuation of the epinephrine effect. What causes that? We know all that already. Okay, these are your non-cardioselective beta blockers. You need to keep this in mind when you're injecting local with epi. So, I knew I had this upcoming lecture. I said for the next 2 weeks before this lecture, I'm going to keep note of who's got what. I had a patient in the office with carvedilol, pendolol, propranolol, sotalol, and timolol. I didn't get Corguard, but I got 5 of the 6 in the last 2 weeks. Diabetes, automatic red flag, period. Any A1C over 9% red flag, they're not a healthy healing patient, especially all of us placing implants. Had a guy come in my office one time, had A1C of 13, wanted me to do maxillary implants. I said, no, they're going to fail. When you get well controlled, I'll treat you. And he did. He got better, and we were able to do some implants. But I said, there's other surgeons in town. You can go see them. So there's the map in 94 of diabetes. 2000. Look, Mississippi standing out. We're number 1 in something. Thank you. But then the rest of y'all caught up with us in 2015, okay? All right? So I'm telling you, I just did this the other day. I always tell my patients, I said, what's your A1C? 6 point, and they get a thumbs up. When I get to 8 and above, and they already know, they said, Dr. Roberson, I know I got to get it down. I'm eating too many sweets and all that. So it's just for your own good, you know? But that's the main thing. I love it when they tell me in the 6s. Great, because that's being monitored over the last 3 months. So angina myocardial, if you're having recent chest pains, red flag. If you're taking nitro more frequently, red flag. If you had an MI within 6 months, red flag. If you're on multiple blood thinners, why? Why are you on a combination? I had a patient the other day, I had to call the cardiologist, like, okay, why are they on Xarelto, aspirin, and Coumadin? And he's like, they shouldn't be on Coumadin. I said, well, yeah. I mean, it's almost like turning a faucet on of just bleeding. Unstable angina, red flag, period. Do not treat this patient until that's under control. My rule of 3, why are you on 3 medications for hypertension, for diabetes? What can you do? If you're taking more than 6 drugs, I call it a red flag. And we've all seen it now. They come in, they get this now Excel spreadsheet. They used to walk in with a grocery bag. Hey, doc, here's my drugs. All right, so what's Azilect and Xadago? Isn't Xadago a cool name? Sounds like a beer or something like that, you know? So what class of drugs? If we prescribe meperidine, Ultramp, or Flexeril, it can lead to coma or death. MAO inhibitor, they've made a resurgence. They've come back into play. Metabolic syndrome. Okay, so functional capacity. How many times we say, Ms. Jones, can you walk up a flight of stairs okay? Well, what we're doing is asking about MET's capacity, which is the functional capacity of exercise for every one of us in this room. Anything under 5 is not a good thing, all right? So, there's basically a specific activity scale. If they can sit up or if they can walk around the house in 1 flight of stairs, that's a 4. So, if you go back to our section on emergency drugs, and they put down there that they're taking, you know, tadalafil or sildenafil, well, you know, they got erectile dysfunction, you know they're having sex, so they're a 6. So they can probably take treatment. So how does this relate to surgery? There it is, 4 METs or under, a higher complication rate. But if you have 10 METs or above, minimal chance of a complication. I mean, it's still there, but it's minimal. Cholesterol, red flag. Obesity, period, red flag. So that's where Mississippi, we're going to win in diabetes and obesity. And, you know, they say 36% of our population is obese. I'll walk into a Sam's Club, I see about 90%. Thank God they got rid of the food kiosk. So obesity is a concern for everything. It's a red flag. Oh, so there we are, well, us, and I just got back from Indiana, so we had a good laugh about that. Us in Indiana were leading the way in 94. Everybody's starting to catch up. Oh, there we are in 2015, looking good across this country, all right? So it's a red flag. Hyperdiabetes, hypertension, diabetes, and obesity. A huge red flag. By the way, a BMI of 30 and above determines obesity. For every number above a BMI, your body creates about 5 miles of extra blood vessels to support your body. Now, the other day, I had about 60, I had a patient in the office, a BMI of 68. That's 420 pounds. She had pericarditis. We had to definitely go in there and do her at the hospital. Sammy, thank you. Think about whenever I do these 8-hour talks, huh? Oh, gosh. So, to summarize some patient red flags, at-risk conditions. Go ahead and start getting, because I'm trying to just categorize things, so when you start seeing these patients, here's some things I need to think twice about. And another one right there, how do we check our red flags? What do we need to do for pre-treatment of those patients as well, too? You can do that medical history there, or you can do the sample, or you can do my smash the ABCs. Yes, sir. Yeah, that's that risk versus benefit right there. You know it's an emergency situation. You're going to make a phone call to that physician. Hey, I've got a patient that's significantly swollen right here. I know they're on this blood thinner, or I know they're on all these medications, but I've got to treat this, or it's going to get worse because now we have a life-threatening airway situation. And that's what you want to have, that you call the physician and got documentation on your chart right there. Now, remember, we always talk about, y'all remember how everybody, I need to call and get medical clearance. Well, it's not really going to be clearance, okay, because you're going to now start getting stuff that will be said to you, yes, you can treat, but you also got to remember this patient is at risk for that, all right? It's more of a medical consultation. Great question. But yeah, we are going to be faced with that. So smash the ABCs. Real quick way when you see that patient, when you come back in to update their H&P, they've been away for 6 months since your last visit. Any medications? Any allergies? Any surgeries performed since you last saw me? How about hospital visits? Aspirin? That covers it, pretty much the whole spectrum right there. Face, arm, speech, time. So what am I talking about? Stroke. Critical right here that the Rover 1 writes that down right there, because if it's a thrombotic stroke, when they get to the ER, they want to know what happened, because within 3 hours they can give them TPA to bust the clot. The hemorrhagic stroke, they wouldn't. Remember, patients with AFibs or AFib is 5 times more likely to have a stroke in your office. TIAs, this is something to really keep up, because people won't write them down as a TIA. They'll write them down as a mini stroke. Up to 40% of all people who had a TIA go on to have a stroke. Within 2 days of a TIA, 5% can have a stroke. Ms. Jones, when did you have that little mini stroke? Oh, a couple of days ago. Within 3 months, 15% have it. So another little documentation to help you as well is the patient risk factor matrix. It covers these 6 things. Now, we've always used the ASA, class 1, class 2, class 3, 4, and 5. This takes it a little bit further. So there's the ASA part of it. Then there's the METs that you just learned about. Then there's the body mass index we just talked about. Then the A1C we talked about. Then the AHAI, which is for sleep apnea. They'll know their score. So you take everything right there, and whatever you determine they are on each category, put it out to the right. So, and then you total up 19, so you go in there, moderate risk. Just another way of trying to prevent something catastrophic happening in your office. Okay, it's Ned time. Never ever do. Never give oxygen to a hyperventilating patient. Never delay giving epinephrine to a patient having an anaphylactic reaction. Never give nitro if the systolic is less than 90. Never give nitro to somebody who took Viagra within 48 hours. Never let your batteries or pad expire on your AED. Never abruptly stop a patient's medication. Oh, it continues. Never position a patient upright who is in syncope. Remember Charlie? Never position a patient supine who is having a stroke. Never give aspirin to a patient having a stroke. Never delay calling 911. Never ever give an expired drug. Never leave a patient alone after a local anesthetic injection. Y'all, I had to cut out so many slides, and I know, because I'm trying to compress it. But there's respiratory post-syncopal obstruction. A 27-year-old was getting a root canal done on tooth number 8. Injection was given. The dentist walked out because he was real busy. Patient left alone. When they came back to the patient, he was sitting in a chair slumped over with agonal movements. He was unresponsive. He was dead. So what had happened, he'd had a syncopal episode after the injection, after they walked out, fell forward, occluded his airway, and that's why he had the seizure, and then agonal movements. He was married, and his wife was expecting a child. So that's why I tell everybody, never ever leave a patient alone after an injection. And never ever drive a patient. So, a patient in your office on these medications, what are they? John, I don't know. Heck, I wouldn't either. But I mean, that's some of the medicines that were approved in August of 2020. Another patient comes to your office on these various medications. What are they? There they are. These were just approved in June of 2021. I don't know if you heard about Advil dual action. They got approved last February. So this is the other part that myself and Jay Resnick have developed, Pharma Dent, that's coming out through Mr. Goldman's company. It's all about pharmacology update for everybody in the office. It's 15 program series. Let me back up. And you also get a new medication alert sent to you every time a new drug comes out. In the last 3 years, we've had almost 160 brand new drugs come into market. How do you keep up with everything? So you'll be getting this in an e-blast. On average, about 8 new drugs are coming out, or 5 to 8 every month. And then Jay and I are going to do a podcast. It's a live podcast called Pharma Docs. And we're going to talk about, for about 15, 30 minutes, every other week through Todd's company. It's free. You listen to it. We're going to talk about all the new drugs that came out. So Goldman Dental Management is where you get Pharma Dent. And you can also contact Steve Harden at AFTO if you need any of these, if you can't find Todd. Remove the ostrich approach. Thank you so very much. Everybody be safe out there. I certainly appreciate you having me today. And that's my email. You can email me about anything. I'm happy to help, always. Thank you.
Thank you very much. So now you reminded us of other things to worry about, right? Okay, so lunch is served.
I'm just getting you ready for that.
Absolutely,
Okay.
absolutely. So do you, in some cases, patients come in your office, you systematically do some blood work to find out about their sugar? Because sometimes they come in there and then they haven't had a physical in 2 years, 3 years, whatever, and they want 5, 10 implants, whatever you were talking, comes in. Do you sometimes insist on having some blood work done?
Absolutely.
And seeing the results? Yeah.
Yes. Here, let me turn. Yes.
And what do you typically would like to know if they come with a blank slate, so to speak?
Right. Okay. So that patient comes in that hasn't been to a physician in a while, and then you take a blood pressure reading on them, get their vitals and all that. Maybe something there triggers a phone call, but like, when was the last time you saw somebody? Oh, 3 to 5 years ago. Well, I want you to see a physician before we do all of this treatment on you. All right. Well, why, Dr. Roberson? Why do you want me to pay all this money for 6 implants up top, and now I got to go see a physician? Well, Ms. Jones, we care about you. We need to make sure there's no underlying health issue going on here before we put you to sleep and do some extensive work in your mouth. Absolutely. And so when they get there, they'll have a CBC drawn. They'll have a Chem 7 drawn. They'll have a liver panel done as well too. Females, they'll have a thyroid done. They'll have a PSA done. Females will have a mammogram done if they haven't had that. If you're 50 and above and it's been a while, you may get a colonoscopy as well too. All right?
The issue sometimes that I've run into, because I don't do as detailed as what you just suggested, and that's good to hear. You find that physicians fight you. They're like, I've had a patient come back and say, my doctor says you are only a dentist. Why do you need to all these tests?
Because what I do every day,
quote unquote.
That's right, what I do every day doesn't just affect your mouth, it affects the systemic system as well too.
Yeah, that was my response. I was like,
yeah, and you know what, one thing I would do, we always try to deal with the nurse because the physician's always so busy, and the nurse is always willing to take the phone call and say, look, we've got a lady in here, we're gonna be doing a lot of work, she's gonna be asleep for an hour or so, and we just want the best for her. And we need a workup done, all right? And, you know, that's a shame that you would get that kind of response from a physician because, you know, bottom line, we're all on the same team here, all right? And you know what? What we do matters to their patients. I mean, it's already proven, you know, there's a link to cardiovascular disease. I have a friend that's a neurologist. He said, oh, we probably spent $2 trillion on Alzheimer's research, and we should have been looking in the mouth first place. He said, he goes, I'm really starting to research this right now. He goes, there's a systemic leak to the mouth and Alzheimer's. I mean, because you start talking about what's called the beta amyloid, that protein builds up in the area called the substantia nigra. So, I mean, that's where we're getting Alzheimer's from. And one of those new drugs I put on there is actually the first treatment drug for Alzheimer's. It's to reduce proteins. So we'll see how that works as well too. But no, it's a shame. I hope that's not all the time. It's just happenstance that this occurred.
It happened once or twice in the last 10, 15 years.
And you can call that gentleman or that lady and say, hey, I'm sorry you may have felt that way, but you know what we do in the mouth really does affect the whole body because I'm going to inject, and that just doesn't stay in the mouth. That affects systemically, okay? So I'm just looking out for our patient, but I certainly appreciate you seeing that patient for me, all right? Turn it on him or her, you know? Make them have a good day, you know? So.
Yeah, thank you very much.
Absolutely.
It was really good. Thank you.
Thank you.
So,
sorry I ran over too.
No, it's okay. I mean, learning is learning. So there's lunch outside. Please go out, get it, bring it in here, or sit over there, whatever. And then we'll start the afternoon with the poster presentations. We have 4 posters that were submitted. It's the second year that we do that. I don't know, it's not a problem. I think it's after lunch, around, what is it now? Almost 2? Il est midi 45.